scleroderma. Because we have two speakers, I'm going to pass on reading their bios just because you've got it, and that will give them more time to speak. But I would like to introduce Dr. Ann Stevens with Seattle Children's Hospital and Dr. Suzanne Lee with the Hackensack University Medical Center.
Thank you very much, Cindy and Mary Beth, for this opportunity to talk today. Is this a good position for the speaker, for the microphone? Okay. So Ann and I are playing tandem, and so let's see if I can figure this out. Okay, no, that wasn't it. That's not it. That's not it. Okay, we'll use this one. No, that's not it either. All right, try that. Okay, so as Dr. Moore told you, there's two types of pediatric scleroderma. So the juvenile localized versus the juvenile systemic. And so typically they're both associated with the hard skin, as Dr. Moore said, but in the localized, it tends to be unilateral. Does this have a pointer? Oh, no, okay. I'm having issues, technical issues. It's okay here? Sorry. Can I get some AV help? All right. Sorry, Cindy, I'm having trouble with the, this. Okay. I couldn't get this to work. I don't know, so. Okay, yeah, just push that. Okay, great. Okay, great. Okay, so for both of them, so with the systemic, we have more widespread skin involvement. Typically, it's more circumferential, but it depends on the subtype. And for both of them, we have this extracutaneous involvement, which is one of the major issues with both of the both forms. So for both of them, we can get joint, muscle, and bone involvement. With the localized, for lesions on the head especially, we can get involvement of the brain, eye, or teeth, oral cavity. With the systemic, we're going to get more major internal organ involvement, such as the gut, lung, and heart. Fortunately, rarely the kidney in children. So I just wanted to show these pictures, which I don't seem to be able to point to, but just to give you an idea of why this is such a problem, because this is normal skin. So we could see that it has a very varied appearance because it's got things like hair follicles, sweat glands, blood vessels. Early on in scleroderma, localized or systemic, we're sort of seeing that we're losing some of this appearance and we're getting these dark bands, which are inflammatory cells going in there. Later on, you lose those and you just have this very homogeneous appearance. So you've now lost all this diversity of structures that skin is supposed to have. So with the extracutaneous, as Dr. Moore said, it's, I'm focusing on the localized scleroderma, sorry. It's been reported as 20 to 70%, but in our prospective studies, it's 50 to 70%. So this is really a major and common problem. And this is going to be more common with the linear subtype, which is the most common pediatric form, as well as mixed morphia, which is also more common in juvenile patients, and pansclerotic, which is also more common in kids. So the treatment for localized scleroderma is going to be based on the severity. So as Dr. Moore said, there's a range of subtypes. So the mild disease, which is typically just your oval plaque lesions, maybe just one, maybe a couple, that typically we are not seeing in rheumatology because that's managed by the dermatologist. And a lot of those patients may never go to see a doctor because it's just, oh, I have this spot. So this could be treated with topical agents, or maybe you don't do anything. Moderate to severe disease is a deeper subtype, so that's going to include the linear, generalized, mixed morphia, pansclerotic. And so this is associated with more extracutaneous morbidity. And also, if you have lesions that maybe it's not clear that it's linear, but it's spanning a joint, or you have a lesion on the head, we're typically worried that this is going to be associated with extracutaneous involvement, which just has not become apparent yet. So in a survey I did of pediatric rheumatologists in this CARE organization, which is North American Pediatric Rheumatologists, to ask how they treat it. And then we came up with plans, pretty much nearly everyone agrees that moderate to severe disease should be treated with systemic immunosuppressants. And the pediatric rheumatologists in England also did a survey, and again, there is agreement on this, this type of management. My usual audio-visual success. Okay, so moderate to severe treatment. The treatment goal is we want to minimize disease impact. Unfortunately, we don't have any cures, which is why we need research, but we do actually have a number of drugs that can control inflammation. And if we control inflammation, we can reduce damage and improve function, reduce pain. Kids, the advantage of them is that they're still growing, so they actually have more rejuvenative quality. So if you actually control the inflammation early on, you get the disease early on, some of the damage actually could be reversed. So we're aiming for normal growth and development. So anti-inflammatory drugs includes corticosteroids, which can be given orally or intravenously. And this is a very strong medicine. It has anti-inflammatory, has immunosuppressive effects. Unfortunately, the effect is not sustained. So if we look at this chart, which is taken from Zulian's study of a randomized clinical trial methotrexate treatment in localized scleroderma, this x-axis is time, the y-axis is time to disease flare, so 100%, time without disease flare. So 100% means, you didn't have a disease flare. So all the patients in that trial got started on steroids. So for the first 3 months, the two arms, placebo versus getting methotrexate, got steroids. And you see that in this 3-month period, nobody flared. Their disease was controlled. Once you stop the steroids at 3 months, then we start seeing people flaring, okay? In the ones that were on placebo, more of them flare, whereas the top line is for methotrexate. So methotrexate is beneficial, steroids is helpful, but as I'm sure most parents know in this room, steroids have a lot of bad side effects if you keep using them, mood issues, and immunosuppressive growth issues. So we don't like to use it for long-term management. Okay, so we are using methotrexate then for long-term treatment, and that also has anti-inflammatory and immunosuppressive effects. Probably not as strong as steroids, but much, much better tolerated for long-term treatment. And this drug has been widely used in rheumatoid arthritis, juvenile arthritis, so it has a good long-term safety data, and there's good evidence for its efficacy in localized scleroderma. So I showed you the plot of the one randomized clinical placebo controlled double-blind study, and that found that 67% of the patients that were in the methotrexate arm improved versus 29% on the placebo. In case series, it's been reported to have 80 to 100% response rate. So part of the difference is that the randomized clinical trial, they had more stringent measures, and in some of the case reports, people just said that they got better, so it's hard to compare. But as probably a lot of you know also, methotrexate has a number of adverse effects or potential adverse effects, a big one being potential infection risk, but that I think is generally not such a big problem with our patients, but GI issues is a pretty big problem, that nausea, pain, poor appetite, oral sores. They can get some lab abnormalities, which generally are pretty mild, but may require lowering the dose or holding it. Mood, anticipatory anxiety, headaches, fatigue, malaise, and for teens and older patients, it is teratogenic, so they need to be on birth control if they're sexually active. Okay, so what are the skin issues in localized scleroderma? So we keep hearing about the fibrosis, the harder skin, and the loss of structures. So this can lead to loss of hair, as we see in this boy with oncutisab. You can have loss of the mobility of the underlying structure. So typically we're worried about the joints, so lesions over joints. We're always concerned about that. Because of the loss of the sweat glands and the fat, elastic tissue, it's going to be drier. It's more potential for skin breakdown, and you can start getting itchy, tingling, or odd feelings there. There's, of course, appearance concerns because pretty much all the patients will get some kind of pigment change, darker or lighter, and then there is typically atrophy of the skin, which again can be subtle or can be more severe. So general skincare management strategies, which you may be hearing some more about from Dr. Chu later, is to moisturize, to protect against the elements, to limit the risk of sun breakdown. So sun can also worsen the dyspigmentation, and good wound care is important. It's very important, you know, these are kids, so we want them to move. We want them to move normally. Movement is part of how kids grow, so it's important to have them have physical therapy, occupational therapy to try to restore any loss of movement, but they should also be participating in regular stretching and exercise programs. For those with severe contractures, they may need dynamic splints. So extracutaneous issues then. Musculoskeletal is the main one. Affecting easily 30–40% of patients. So this is going to be joints or muscle, and so joints, they can have pain, arthralgia, they can have inflammation, arthritis, or they can have arthropathy, which means that there's limitation, but we're not really sure if that's just from fibrosis or there's some inflammation there too. So typically there might be some limitation in the range of motion, which is fixed, which are contractures. There can be abnormal angulation, as you can see in the lower picture, that the child's ankle is not at the same, on the left is different than on the right. Muscles can also have inflammation, so you can get myositis or you can get pain, myalgia. There can be atrophy or spasm, which might be controlled by Botox. And then growth problems is a big concern, so that the affected side can have undergrowth. And this really can affect any of the tissues in that path of the lesion. So beside the skin, we're having muscles, joint, bone, breast, other tissues, and there's some MAC issues. So that was supposed to be an arrow going to the left. But head lesions can lead to facial hemiatrophy, and arm or leg can lead to a shorter digit or a thinner or shorter limb, as we can see in these two pictures. So the boy on top has Parry-Romberg and a cul-de-sac. So the right side of his face is smaller than the left, leading to some distortion. And in the child on the bottom, her right leg is also shorter and thinner than the left. And this is really a common issue. So in our two prospective studies of 90 and 50 juvenile localized scleroderma patients, we found the frequency over 20%. It's unfortunately difficult to identify this often, and it's difficult to quantify. So because some body asymmetry is normal, we're not perfect. So I tried to look through orthopedic literature to find out what's a normal leg length difference. And so people tend to say 0.5, but then there are marathon runners who had a 2-centimeter difference, which is about an inch difference. Obviously, you could run marathons and we're fine. So we don't really have fixed criteria. And these growth differences may not be apparent until the child enters the growth spurt, when now we're having the difference in growth rate becoming more manifest because the good side is growing much faster. So there isn't such great, at that point, I think probably the damage may already be done. So the best option for minimizing this is really to try to control the disease early. Because again, as I said, kids have this great growth potential. So some of the difference may be reversed, but at least it will be minimized. For patients that have head lesions, there can be involvement of the eye, mouth, or brain. Eye can range from inflammation in the eye, uveitis, to dry eyes, to lid issues. In the oral, we often have teeth issues, so good dental care is important. Sometimes there are root issues that the root of the tooth did not form fully. There can be malalignment because of bone issues in the jaw or because of the tooth itself. And in the brain, headaches occur much more frequently than seizures. Abnormal imaging on brain MRI is seen, which is unclear significance often. So there is debate as to how often that needs to be done. Some studies, just very small studies, have not found a change in patients over time, but again, very small studies. Other neurological issues, which could be for those having the lesion on the head or peripheral, is neuropathy, which can be associated with focal movement disorders such as twitching or spasm. Again, Botox can help with this. So for patients who are intolerant or fail methotrexate, we have limited knowledge as to what's best to do. The most commonly used drug for these patients is mycophenolate mofetil Salcept, and that's been based on really 2 small case series, but it's a major drug that's used for transplant patients. So transplant frequency has really increased dramatically over the last 2 to 3 decades because of this drug. So it is considered to be pretty well tolerated, safe, much better than the drug that was used to treat transplant patients before Salcept. Adverse effects include diarrhea, cramping, infection, bone marrow suppression. It's also teratogenic. Less commonly used are hydroxychloroquine, which is, I think, is a weak drug, so not something that you would typically use for someone with very severe disease. As azathioprine, imatinib. Biologics have not been formally studied, but there are a number of case reports, and we know that these drugs are often good for patients with arthritis, and so some of our patients have arthritis, so it's been used in these patients, has been shown to be a benefit, but it's also been used in patients that don't have joint issues. And cyclophosphamide is a very strong immunosuppressant, so that's, but it has very toxic side effects, so that's really reserved for very severe cases. And other treatments are going to include topical creams, which are mostly for mild superficial lesions or can be used as an adjuvant to any systemic treatment. Phototherapy, this is something that the dermatologists use. So if we use it, we do send the patients to dermatology. It seems to be different what we have available in the United States than what's available in Europe, where most of the studies have been done. So what they have penetrates deeper, seems to work better, but that's concerns about phototherapy penetrating deeper is that you may be more at risk for skin cancer or premature aging. So that hasn't been adopted in the US. And we don't really recommend that phototherapy should be used for patients with deep lesions, but somebody that has generalized a lot of skin involvement, it can help reduce some of that thickening and some of the discoloration. Non-steroidals like ibuprofen, Advil, Motrin, naproxen, they can help with relieving some of the pain, but really not effective for inflammation control. And then, as I said before, physical therapy, occupational therapy, encouraging your child to be active, stretch, can be anything they want to do, but basically to keep moving. I think, okay. So then there are surgical interventions for some patients. We're going to touch a little bit on this in the next talk, but for patients that have facial lesions where there can be some asymmetry or lots of atrophy, then fat, stem cells, and other materials have been implanted and can improve the appearance contour. Some have used bone grafts to try to improve also. Botox, as I mentioned, can relieve pain. Orthopedic interventions include correcting the angulation of the joint, limb length difference, tendon release, and in general, just like a word of caution about surgery is that it's better to delay it, if possible, until the disease is inactive, not that the disease is active. Because we don't know, what we'd all love to know is what causes this, but in 10 to 15% of patients, it's associated with trauma. So surgery is a type of trauma, and there are reports of the disease flaring after surgical correction. So it's best to wait until the disease is inactive before surgery is attempted. And then, so how long do we treat? Another question we'd all love to know. Okay, so this is a chronic disease like most autoimmune disease, and the course is variable. So we have some patients that are active, but it goes into remission. Then we have others that it's active, it goes into remission, but then it comes back and it goes into remission, and that can go on. And some that just are always active because we don't seem to be able to control it. Fortunately, those are very small. The duration of childhood disease is much greater than adult. So this has also not been well studied, but in the one study where they had about 120 adults and 120 children with localized scleroderma, the median duration for the child was 13.5 years versus 5.6 for the adult. And this was done before we have the current treatment practices, so we hope that we are actually improving this and it's lower, but again, no formal studies on this. There's one randomized clinical trial where they had 65 patients. They did a long-term follow-up. So about 60% achieve remission off of methotrexate. So these are in remission off medicine. Another 20% achieve remission on the methotrexate. So about 80% in remission on medicine or without medicine. So basically, we do need more long-term studies. We need to follow patients for years to really be able to better address this. And I think that's it for me. But then I cut into your time. I don't know. Any questions or we?
Or the capillaries not being changed?
So the question was, what signs to look for that the disease is in remission? Is that right? Okay. So that's a very tricky issue because, as I said, damage is very common. So I think that this is a big point that I try to get across to other physicians is just because you see a damage sign does not mean that the disease is in remission, because when it flares, you may then get return of the erythema, which is an active sign, as well as skin thickening, as well as this waxy white appearance. But you sort of need someone who's going to be attuned to looking for this, because otherwise I see patients, that have been told that their disease is inactive, and it's clearly not inactive if you know what you're to look for. At my site, we also do ultrasound so we could better assess the deeper tissue layers, because sometimes the skin looks totally inactive, but then we find that there's signal in the muscle. So, and other people might do MRI. So nail file capillaries is maybe more for systemic disease. Sorry?
I think she was asking about systemic.
Okay, so maybe I'll leave that for Anne to answer when she gets that. Sorry. Any other questions? Otherwise, I'll give it to Dr. Stevens. Thank you.
That's the trick with the changing of the slides.
So you have so it's this button point at the screen.
Say again?
This button to point at the screen, otherwise use the mouse.
This middle one?
No, this one.
That
This unlabeled
Okay.
mystery button.
Good morning. It's 3 tough acts to follow, my goodness. Good start to the day. Can you hear me okay? So I'm Ann Stevens, and we separated this talk into the localized versus the systemic sclerosis to emphasize once again that we really think about these diseases very differently. They probably have similar causes and different causes at the same time, if that makes sense. And sort of related to a question that was asked earlier today, there are autoimmune genes that predispose to getting one of these diseases. And then there's probably a second disease that's a localized scleroderma gene, and then a different gene that's a systemic scleroderma gene. So that's kind of the way we're thinking of it right now. And that's why you'll see that some of the treatments are very similar between localized and systemic. And, but the evaluation and how we approach treatment is extremely different. So you've heard that systemic sclerosis is more often leads to not just the skin, but the internal organ involvement, and we're very, very concerned about that. So what I want to talk to you about this morning is how we evaluate a patient, how we decide whether we need to change the medicine or not. What are we doing in every one of those clinic visits? And they're really threefold pieces of the puzzle that we try to assess every single time. And it's difficult we might only have a half an hour with our families in a clinic visit, if we're lucky, an hour. So we try to get as much information as we can and make the best guess we can. So these are your pediatric rheumatologists. We look like goofballs. We had a really good time last night. But we're really constantly sort of scratching our heads, and just put your hand up if you think we need more research in this area. Thank you. So we're working on it, but I'm pretty excited. We're making really great progress. I think the momentum in scleroderma research is really strong right now. And when we talk about research later on this morning, I think you're going to be excited with us. So these 3 pieces are: 1, how does the patient feel? how does the parent think the child is doing? So that's why we ask all these questions about what's going on in school, what are you doing after school, and ask the parent, what is the child like in the morning? Are they sleeping okay? What do you think? That's a hugely important piece in our decision of what to do with the treatment next. The second piece is our physical exam, and the third is the laboratory tests and the radiology tests. So those are the three things that we consider. So regarding the history and the exam, one huge thing is the Raynaud's, the blue hands. And I'm talking about not just what Joanna was talking about when she had blue hands when she was 12 years old, true Raynaud's, blue hands, and white phase. So the blood vessels clamp down, the blood can't get in, and then they turn blue and the blood comes back in and it doesn't have any oxygen. This is not a common and normal thing in children. 15% of adults have Raynaud's. I have Raynaud's. I moved to Seattle, I got Raynaud's. It's cold and damp. That's normal, primary Raynaud's with no underlying disease. In children, we worry a lot in a child that has true Raynaud's. This is the white phase, so you can see that the fingers are white and there's a very sharp demarcation where the white stops. So that's different from what we call acrocyanosis, where a lot of kids can get just blue hands, kind of mildly blue hands. That can be associated with anorexia, with ADHD medicines. Some kids just have poor circulation. So we're talking about the true blue Raynaud's. So every child with Raynaud's needs to come to the rheumatologist to get a full evaluation. And the reason is because 30% of these kids, that's a lot, are going to have some kind of autoimmune disease, what we call a connective tissue disease that's affecting the blood vessels. And there's a couple of studies that show within 6 years, 30% of these kids can get it. Most are within 2 years. So this is such a hard clinic visit. This is, your child has Raynaud's. She doesn't have scleroderma or lupus right now, but she might get it, so you need to keep coming back to the rheumatologist. We really need better tests to be able to make that prediction right from the beginning. So that's one of the things we work on. Oh, there's no picture. So I always think about Julia Child in these cases, who her recommendations was you throw a beautiful dinner party, you make this lovely dinner, and it's a total flop in the kitchen. So you just smile and say, bon appetit, and pretend nothing's happening. So imagine that there is a hand, and the hand has what we call sclerodactyly, so tight fingers, swollen fingers. If we're in the inflammatory stage, that's what we're looking for in a child with Raynaud's. And then we take a magnifying glass, or sometimes we just hit gel, and then we look with the ear looker or the eye looker with a magnifier on it, and look at the capillaries that are right next to the nail beds. And they should barely be invisible. There should be tiny little lines all lined up like little soldiers. In scleroderma, if the disease is active, we may see big vessels, big red vessels. We may see a loop. We may see them winding around like trees. We may see them gone. We may see like a big one and then no vessels at all in the area. So that's what Dr. Moore very nicely described, how scleroderma affects the blood vessels. And that's our little window into the blood vessels. Digital ulcers. This is a fabulous picture of digital ulcers. Yours came out okay, huh? So that's the other thing we look at, and often we will ask, have you had sores on your fingers? And the answer is no, and then we'll look and we'll see these tiny little sores, little scars on the tips of the fingers. That also should never happen in a healthy child, and that would be a sign that this is a scleroderma patient with scleroderma. So let's talk about treatment of Raynaud's, just for this one piece. So I'm going to focus on different pieces of systemic sclerosis that we treat differently. So as my mom would say, prevention is the best medicine. The best thing we can do at the beginning of Raynaud's is to avoid triggers. So avoiding cold exposure, we ask kids to put on warm gloves, sit on their hands in class to keep them warm. You need to keep the whole body warm. So if kids in Seattle go out in the cold rain, their body gets cold, and then their hands are not going to have good circulation. You gonna try it? Is it reading off the PDF? We recommend to all kids that they quit smoking. Highly unrecommended. Also, pregnancy unrecommended for children. Most of the medicines that we give. Whoa. Now it's on the main thing. Let's try it. Hmm?
I think Cynthia put it on the desktop.
Okay. So how do we go down there? There. Oh, 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 oh. There it is. Talk among yourselves.
Slideshow.
No, we had one picture. The other pictures were there. These pictures are lost. Avoiding caffeine and emotional stress seems to trigger Raynaud's. So a lot of hospitals, Seattle Children's, we have a program in biofeedback under the adolescent medicine umbrella where kids can learn to control with their minds the dilation of their own blood vessels. If these more moderate preventative measures don't work, then and this is really causing a problem, it's causing pain, causing sores to occur on the fingertips, then we might recommend blood pressure medicines. So nifedipine and amlodipine are the most commonly used blood pressure medicines that will open up those blood vessels and allow the blood to get to the fingers to feed the tissues so that they don't get those sores. And then if that's not strong enough, then we move on to medicines like Viagra and Bosentan, which actually heals the blood vessels. It works on the cells that line the blood vessels to help them to be more healthy and allow the blood vessels to expand when they need to get the blood to the tissues. If those more serious medicines don't work, then we might move on to a nitroglycerin paste, which is a paste that immediately expands those blood vessels. And that might be for very severe Raynaud's, maybe in one finger, where a sore will not heal. Sometimes we have to bring kids into the hospital and we put an IV in and use prostaglandins, which expand blood vessels all over the body. And then sometimes we need to do surgery on the nerves, kind of like what Joanna was talking about, that she needed to have a surgery to cut the nerve that's making those blood vessels clamp down. So what about the other problems in kids with systemic sclerosis? We use lab tests in order to determine how often we're going to do tests and which tests to do in which kids. And this is not a slam dunk area, but we're learning so much that we're using these lab tests more and more to help guide us in therapy and frequency of monitoring. So the tests that we use to determine who's going to get what type of disease, who's going to get GI disease, who's going to get pulmonary disease, who's going to have really bad skin disease, who needs serious medicine right now, who can wait and we can watch them a little bit longer, who needs to have a lung test every 3 months, who can wait for a year to have their lung test. So these are the autoantibodies. I'm going to try it again. So we know now, Dr. Moore's talk, that the immune system can make antibodies that bind to our own proteins. And the anti-nuclear antibodies are the really suspect antibodies in scleroderma. The two major ones are the SCL70, and that's associated with the diffuse systemic sclerosis. And the centromere is another protein in the nucleus that's associated with limited systemic sclerosis. So these are two types under the systemic sclerosis umbrella. And there's a lot of confusion because they shouldn't have used that limited word. It sounds too much like localized. So don't get that confused. These are both systemic sclerosis, diffuse and limited. Yeah, next slide. Next slide. Thank you. Okay, so those are the ones we've been testing for many decades. Now we have a whole bunch more, and that was a whole list of them. And we can now, it's commercially available, a bunch more of these nuclear antigens. And the problem has been in the past that there's a lot of kids who have the anti-nuclear antibody, they have the ANA, but they didn't have an SCL70, they didn't have a centromere antibody. So what is this, and what do we do about it? This ANA is clearly not, is clearly associated with their disease, but we didn't know how to think about the disease because we didn't have a specific antibody. So now we have a whole panel of these other these proteins that are in the nucleus that we can test for. We send blood to Oklahoma, and they can do this big panel of tests. And they can give us a better hint as to who's going to get GI disease, who's going to get pulmonary disease. And there was we've just come back for the annual big rheumatology meeting with 15,000 rheumatologists descending on Chicago last week. And there were a couple of studies, very large studies of 1,000 adult patients, where they watched the patients for 20 years. And they look at the beginning, did you have antibodies to the SCL70? Did you have a fibrillin antibody? What did you have? And then 20 years later, who had terrible lung disease? Who had terrible GI disease? Who had heart disease? And they could make very nice associations. So I think the science has come out of the research realm now, that we can use these more clinically, that we can order these in clinic and we can use them to help guide our testing and our therapy. It really hasn't been there until now, but it's this extensive research, at least in the adult patients, that we're going to extrapolate from the big babies, as Dr. Moore calls them, to the kids.
You could do this one. That's fine.
Yeah? Are we there? So I mentioned SCL70 antibodies associated with diffuse systemic sclerosis. And by diffuse, we mean widespread. So not just the hands and the fingers, but goes all the way up the arm. Thank you very much. All the way up the arms, legs, the face, skin diseases everywhere. And this disease, it's important to identify these patients because their internal organs are going to be affected more quickly. And in contrast, the limited kind is not all the way up the arm, but mainly just on the hands. And these patients tend to have very severe Raynaud Phenomenon, and they have later internal organ involvement. Then in kids, we very often see this overlap, which can look like lupus. It can look like dermatomyositis, which has skin disease plus muscle disease. It's a pediatric autoimmune disease that can occur totally independent of scleroderma, but we see this signs of dermatomyositis and lupus in some of these kids that have true blue scleroderma. And we can very often see arthritis in these kids. So I have some patients who have what looks like true juvenile arthritis, and it looks like scleroderma, and it looks like lupus. So I'm trying to treat all of them at the same time and do this balancing act of which medicines to use. We derive a lot of our data from a lot of our clinical judgment from the adult data, but it is clearly different in kids and adults. In kids, we see more of this overlap disease. We see less of this limited disease. And the prognosis in kids is much better. They don't have this renal crisis that adults have, which can be have extremely high morbidity and mortality associated with the renal crisis. So we don't see that in the kids. We see less lung, heart, and esophageal involvement. That doesn't mean we don't see it. We certainly see it, but less. But we see more musculoskeletal involvement. So this is a comparison of all those autoantibodies I was talking about in kids versus young adults, so like 20, 30-year-old adults versus older adults. And what you can see is in some of these antibodies in red are lower in the kids. Some of them are higher in the kids. Those are in blue. And there's still 20%, even though we did this study, you looked at all these different nuclear proteins to see which antibodies are recognized. There's still 20% of these kids who we don't know. We don't know what the ANA is. So we got to keep doing this research and trying to search for what those proteins which protein is being recognized. And that may give us a clue as to what's causing the disease and give us a clue as to what's going to happen to that child. So some other tests that we might routinely look at in a child. We always do a cell count, a complete cell count, and that gives us a hematocrit, which tells us if the child is anemic. We might look at iron levels, and we sometimes look at vitamin levels, like vitamin B12, vitamin D levels. And those can give us a clue as to whether the gastrointestinal system is involved. And that's because kids with GI involvement tend to have malabsorption, and so they're not getting all the nutrients they need. We routinely do muscle enzymes if a child has had myositis, so we do them at the beginning when we first diagnose a child. And then if they've had myositis, then we might monitor those to see if the muscle disease is active. And that would be a reason for us to up the treatment. And then we look at inflammatory markers, and that might give us a clue as to whether arthritis is active. It might give us a clue as to whether the child has an infection, which is a constant concern because these patients are on immunosuppressive medicine. These inflammatory markers, the sed rate and CRP, we do them, but they don't always tell us yes or no, there's inflammation or not. So they're not super sensitive in scleroderma. And then sometimes we do skin biopsies. So we have this skin score, which is when we pinch the child all over, and we score how thick the skin is. So I don't know if your child has had this done, but we might pinch them at all these key places around the body and then score 0, 1, 2, 3 for each of these areas, fingers, hands, thighs, so forth, and then we add up the score. And this is developed for research purposes so that we can put a number on how bad the skin disease is. But a lot of doctors do it for clinical purposes too. So over time, we can monitor how the child is doing. Are they getting worse? Is the score going up? Or is it getting better and the score is going down? The caveat is that this is tricky in kids because kids have nice, plump, healthy skin. So it might feel normal even in a healthy kid. So it might be good in an individual child over time, but probably at the beginning to use this score to tell if there's scleroderma or not is not going to be useful. So focusing only on the skin disease right now, how do we treat it? Similar to localized scleroderma. Steroids to start out. Let's stop the inflammation, get it under control. Then we want to get them off the steroids, so we might try methotrexate, mycophenolate. If it's very severe skin involvement, I have used cyclophosphamide or rituximab, which wipes out the antibodies, the cells that are making the antibodies. We think the antibodies are contributing to the disease, so let's kill those cells off. We don't want to jump to that immediately because, of course, the child needs their immune system. They need their antibodies. They need to respond to the flu vaccine and all of their other vaccines. And if we wipe out those cells, then they may not have those responses. And then if all those medical interventions fail, then we have stem cell transplantation. In the early stages of research, we have a couple of biologics, which we are starting to use routinely when those top medicines don't work. And they are Actemra and Orencia. So those are medicines that we used to have to give by IV. Now we can give them by subcutaneous injection, but they're biologics, they're proteins, so you can't take them by mouth. So that was skin disease. Let's talk about lung disease. Interstitial lung disease, inflammation around the airway spaces in the lung, and pulmonary fibrosis downstream of the inflammation. I think in the future we're going to be thinking of those treating those stages differently. We're going to have tests that tell us there's inflammation and tests that tell us there's fibrosis, and we'll probably treat it differently. And then we worry about pulmonary hypertension. So what's this? Got it. 2 minutes. This is the heart. This is the back. These are the lungs. This is fibrosis with those black spaces are holes in the lungs. It should be healthy gray lungs. This is scleroderma lung disease. And what do we use for it? The same medicines being studied. We're going to show you some data in the research part, tocilizumab. Moving on, what's this? Does anybody know what that is? The barium swallow. So this is the kid drinking the chalk. Should be a nice smooth column all the way down. This is what fibrosis looks like. This is what we're looking for. That area to the left is an area where the barium's not able to go through. And this is a stricture at the bottom. So we ask, do you have a problem swallowing? See how the barium's getting stuck because there's a stricture. Very under-recognized, a GI disease. Undertreated, probably. The highest association in patients with scleroderma with poor quality of life. In a child associated with malnutrition, associated with poor growth. So we're extremely concerned about this. This is the BMI in the scleroderma patients on the very right, and myositis, juvenile arthritis, lupus, and localized scleroderma have pretty normal BMIs. These patients with systemic sclerosis, very low BMIs. So these kids are not growing very well. They're not gaining weight as they should. And so we're using these radiology tests, but we're also working to start using way more questions of the child. So we have this new tool that you may start seeing in clinic if your child has systemic sclerosis, where we have 34 questions. Do you have trouble swallowing? Do you have heartburn? Blah, blah, blah. And then we're trying to detect more of this GI disease early on by what the patient tells us. So how do we treat that? Prevention, keep the head of the bed up. Don't eat before bed so that the food in the stomach doesn't go washing up into the esophagus, causing acid damage. We try to make sure that the child's getting enough nutrition. So some kids who are not gaining weight may need protein shakes, may need foods that are easy to swallow if they have a stricture. And then we use a lot of antacids to prevent that damage of the esophagus from the acid that's washing up into the esophagus. Sometimes we need motility agents, so these are medicines that help the squeeze of the muscles if the fibrosis has damaged the muscles, so it's not able to push the food through the esophagus and then into the lower gut as well. Sometimes antibiotics, if the muscles don't work so that the food sits there and bacteria can grow in it, that can cause a lot of bloating and discomfort, and antibiotics may be necessary. And then octreotide is a more serious medicine for this dysmotility problem. There are a couple of medicines that you can get in Canada that we don't have here that a lot of the rheumatologists are also recommending. And then we use the same immunosuppressants because we think it's the same immunological process in the gut as in the lungs. Why some kids get more gut and some more lungs, we don't know. So overall, immunosuppression medicine, preventative measures, and then good dental hygiene care, get the teeth sealed so that if there's a dry mouth, that the kids don't get cavities. Some kids need artificial saliva if their mouths are really dry. You'll hear more from the dermatologist about topical treatments, including this honey-based treatment. And everyone should get exercise, in my mind. Our goal is for kids to be like Joanna, living life to the fullest. We really want everyone to live a little. So thank you very much. We've gone a little over time. Do we have time for some questions? No? So we're going to take a break now?
Yeah,
or
maybe during the break they can see you if they have questions.
Okay, yeah. Part of what I really love about this meeting is being able to hear individually your stories, and that gives us an idea of what we need to do for research and how we can better understand our patients. So thank you for being here. Yeah, sorry, we're way over.